Good day, everyone. For this session, we will be discussing approach to terminal extubation and end-of-life care, addressing common ethical issues. I am Dr. Liza Manalo, a palliative care specialist. These are our learning objectives for today. We are not the owners of our lives, and hence do not have absolute power over life. We have the duty to preserve our life, but the duty to preserve it is not absolute, for we may reject life-prolonging procedures that are insufficiently beneficial or excessively burdensome. Competent patients have the right to refuse any medical treatment, even if the refusal results in their death. We have to make a distinction about dignity of dying. In the pro-life context, the intrinsic value and personal dignity of every human being do not change. It is not diminished by illness, suffering, malformation, or insanity. Moreover, biological or psychological adversity can be an occasion for further ennoblement. As St. John Paul II affirms, man's great dignity is confirmed in a special way in suffering. However, in the pro-choice context, human dignity is undermined or even treacherously destroyed by suffering, weakness, dependence on others, and terminal illness. It is therefore necessary to rescue the dying process from these degrading situations by means of recourse to euthanasia or physician-assisted suicide. The right to a dignified death, or the choice to die with dignity, is closely linked to the right to choose the time and manner of one's death. Euthanasia is an act by a person, usually a physician or other healthcare provider, actively and intentionally to end another person's life by some medical means, injecting a short-acting anesthetic induction agent intravenously to render the patient unconscious, followed by pancuronium or similar to paralyze all movement so the patient dies of asphyxia at that person's explicit, voluntary, and competent request. Physician-assisted suicide is an act whereby a physician or other healthcare provider deliberately and intentionally helps a person to commit suicide by providing a medication for self-administration, usually a massive barbiturate overdose, at that person's explicit, voluntary, and competent request. The World Medical Association condemns as unethical both euthanasia and physician-assisted suicide. Palliative care neither hastens nor postpones death. Palliative care is about care at the end of life, not about ending life. The most appropriate initial response to a request for hastened death is to intensify palliative care. Dying patients who request euthanasia should receive loving care, psychological and spiritual support, and appropriate remedies for pain and other symptoms so that they can live with dignity until the time of natural death. Life-sustaining treatment is any treatment that serves to prolong life without reversing the underlying medical condition. It may include, but is not limited to, mechanical ventilation, renal dialysis, chemotherapy, antibiotics, and artificial nutrition and hydration. Are physicians legally or ethically required to provide all life-sustaining measures possible? No. On the contrary, patients have a right to refuse any medical treatment, even life-sustaining treatments, such as mechanical ventilation or even artificial hydration and nutrition. Withdrawing unwanted treatment is entirely consistent with the four ethical principles of beneficence, non-maleficence, autonomy, and justice. It is important to remember that medical treatments in themselves are ethically neutral, and their relative benefit can only be ascertained from the specific patient's particular diagnosis, prognosis, quality of life, goals of care, and beliefs and values. When death is imminent and without interruption of the normal care the patient requires in such cases, it is ethical, according to science and conscience, to renounce treatments that provide only a precarious or painful extension of life. Determining whether a treatment is ordinary or extraordinary depends upon the balance of two sets of factors. If the good outweighs the harm, then it can be reasonably affirmed that the means is morally ordinary or proportionate. If the harm outweighs the good, then disproportion probably exists and the means is probably morally extraordinary or disproportionate. Extraordinary means usually refer to highly specialized, physically difficult, psychological draining, or very expensive measures used in order to delay the imminent death and prolong the life of the dying patient. These extraordinary means no longer correspond to the real situation of the patient, either because they are by now disproportionate to any expected results or because they impose an excessive burden on the patient and his family. Discontinuing medical procedures that are burdensome, dangerous, extraordinary, or disproportionate to the legitimate outcome, to the expected outcome, can be ethical. It is the refusal of overzealous treatment. Here, one does not will to cause death, one's inability to impede it is merely accepted. The decision should be made by the patient if he is competent and able, or if not, by those legally entitled to act for the patient, whose reasonable will and legitimate interests must always be respected. A power of attorney or surrogate is obligated to choose what they think the patient would have wanted, even if it conflicts with what they themselves would want. The law recognizes a hierarchy of family relationships in determining which family member should be the official spokesperson. Usually, if the patient is married, the spouse, if the spouse has no decision-making capacity or is not around adult children of the patient, in pediatric patients, it's usually the parents, and if they are not capable or not around, then it's the adult siblings of the patient. Discussions with patients on their decision of the surrogate on withdrawing and withholding treatments should include a review of the following: the patient's medical status and prognosis, a review of previous advance directives, the benefits and burdens of specific interventions, the patient's beliefs and values, the proposed treatment plan, and clarification that ineffective and or unwanted interventions can be withdrawn at any time. When facing decisions about withholding or withdrawing life-sustaining treatment, the physician should discuss with the patient or surrogate the option of initiating an intervention with the intention of evaluating its clinical effectiveness after a given amount of time to determine if it has led to improvement. Confirm that if the intervention has not been achieved or the agreed on goals are not achieved, it may be withdrawn. Oxygen-enriched air via a nasal cannula or mask is a light burden intervention, as is an NGT. Oxygen provided by a ventilator represents a much greater burden of care. This is because of the physical discomfort of the ET. Sedation, analgesics, and physical restraints are often necessary. The patient cannot talk, and the ventilator exposes the patient to greater risks of infection and barotrauma. First and foremost, establish that further aggressive medical care is incapable of meeting the desired goals of care. Examples include patients with severe irreversible brain injury, metastatic cancer, or overwhelming sepsis. Once it has been decided as such, discussions about ventilator withdrawal to allow death would then be appropriate. The goal is to remove unwanted treatments rather than to hasten death. Understanding this is essential in clarifying the distinction between active euthanasia and death that accompanies the withdrawal of life support in the ICU. The legal and ethical principles guiding withdrawal of ventilatory support in end-of-life care is patient autonomy. Assuming all other life-sustaining treatments have been stopped, including artificial hydration and nutrition, there are three potential outcomes: rapid death, death within hours to days, and stable cardiopulmonary function. Like other medical procedures, withdrawal of life support should be accompanied by informed consent. Related issues to be discussed prior to removing mechanical ventilation includes withdrawal of artificial hydration or feeding, withdrawal of blood pressure support, withdrawal of antibiotics and blood products, withdrawal of ET tube after ventilator is discontinued, and wishes concerning organ donation. There is no compelling ethical or medical rationale for continuing any of these treatments once a decision has been made to remove mechanical ventilator. Although the attending physician must take ultimate responsibility for the decision, it would be imprudent to insist on a plan in the face of persistent, thoughtful disagreement by members of the healthcare team. The attending physician must accept ultimate responsibility for the decision to withdraw ventilator support and for its humane and skillful resolution. The most common symptoms related to ventilator withdrawal are breathlessness and anxiety. Opioids and benzodiazepines are the primary medications used. Concerns about unintended haste and death are exaggerated, particularly if established dosing guidelines are followed. Are you kidding the patient when you remove the ventilator and give opioids to relieve the pain and/or breathlessness? No. The intent and sequence of actions are important, as are the means chosen. If the intent is to secure comfort, not death, if the medications are chosen for and titrated to the patient's symptoms, if the medications are not administered with the primary intent to cause death, then ventilator withdrawal and pain treatment are not euthanasia. Withdrawal or withholding of treatment is a decision or action that allows the disease to progress on its natural course. It is not a decision or action intended to cause death. In rare circumstances, opioids and other drugs are rapidly titrated to treat physical symptoms following accepted dosing guidelines. They may be perceived to contribute to death. However, provided the intent was genuinely to treat the symptoms, then such use is not euthanasia. Impediments to good care include misconceptions about legal and ethical issues. These are the major distinction between palliative sedation and euthanasia. When a family is able to make a definite decision for ventilator withdrawal, such a decision is always emotionally charged. Grieving family members may suffer from guilt at killing their loved one. In such instances, the gradual withdrawal of other life-sustaining therapies over a period of hours to days prior to ventilator withdrawal has been associated with improved satisfaction. Ventilators are frequently the last therapy discontinued prior to death. It is important to provide a multidisciplinary approach to support, including chaplains and other psychosocial support staff. Allow time and space for reflection, answer questions honestly, and offer empathy and assurance. Let's now talk about ethical issues in pandemic planning and response. A scarcity of ventilators during the pandemic will require an allocation policy based on different ethical guidelines than those governing usual clinical care. Increasing the number of lives saved may take priority over patient autonomy. Two criteria for giving high priority to patients with respiratory failure during a pandemic include high likelihoods of survival and short-term need for mechanical ventilation. Patients with respiratory failure should receive respectful and compassionate palliative care. Even doses that will cause unconsciousness are appropriate if lower doses fail to relieve symptoms. There will be instances where decisions will be made to withdraw life-sustaining therapy, such as mechanical ventilation, at the emergency room for the imminently dying COVID-19 patients. The recommendation is to not extubate the patient in the emergency department, but to decrease ventilatory support and ensure comfort throughout. Death is not the failure, suffering is the real failure. Palliative care anticipates, prevents, and reduces suffering, offers appropriate information, psychosocial, and spiritual support. Patients should be provided the spiritual support as well as the opportunity to receive the sacraments in order to prepare well for death. The experience of grief and the need to heal unites humans worldwide. During the COVID-19 pandemic, it resulted in tremendous strain on healthcare systems and unprecedented grief and suffering for healthcare workers and caregivers. Thus, with one voice, we celebrate the importance of palliative care to quality of life. and advocate for equitable access for all. That's why this year, we celebrate World Hospice and Palliative Care Day with the theme Healing Hearts and Communities. Thank you very much for listening. These are my references.